There isn't a day as an ADAP administrator that I'm not reflecting back on reports and data that we're calling out of our database as we're making decisions that are there. They come at very critical points in strategic planning, become important at times that we're doing some of our financial forecasting for upcoming fiscal years.
Forecasting and really checking into utilization and cost per client. And one of the things that I learned at probably at a conference, going to Lanny's forecasting session, really using his forecasting tool and doing a good job of entering monthly data rather than quarterly data, even though our ADAP data report is a quarterly report. We find it a lot more effective to take a look at it monthly.
We use it as we're developing our monthly reports to our governor and to our legislative bodies, trying to project to them where ADAP is at that time. Illinois ADAP, when I first arrived 3 years ago, was at a financial breaking point. We were months away from going to a wait list. And it is the data that our system was collecting that was able to tell the story to our legislative body and to our governor that actually helped for an infusion to prevent a wait list in our state.
When I came on, it was really the two types of data that were really the most helpful for me. One was financial projection data, getting to understand, how much money we were spending and on who and on what drugs, and then being able to take that information and project it forward so we could figure out how much money we were going to need, and then if there was a financial problem or a shortfall, then we could begin working on that earlier than later. So that has really helped me, using a good budget and financial expenditure projection data. That's been extremely helpful in keeping the Texas ADAP solvent. We've never had a wait list, but we do those projections religiously, and I'm always looking at it almost daily.
I always say we're on life support, and we're always called upon to justify the work we're doing. And so I've used data to create monthly reports that actually go up to the governor's office and to the assembly to let them know what is the story and the heartbeat of our ADAP program, which has really benefited us in times when the majority of our state has been taking financial cuts. We are the one program that hasn't taken a hit, that we have some sustainability because our data was able to tell the story.
Then the other type of data that I've used a whole lot in the program is improvement data, quality improvement data, because our role in ADAP is to help people access medications, and that in itself is pretty straightforward and simple. But improvement data has helped me tremendously on how to do that more cost effectively, how to do that more expeditiously. So the improvement data helps me tremendously in just being able to deliver those services in the best way possible.
We also use that data through our system to actually meet some of our performance measures and objectives from HRSA. One very key one that we monitor monthly is inappropriate regimens. So our system actually does an automated search on all dispenses that have occurred over the month, and if there's any inappropriate regimen that meets the categories outlined by our HRSA regulations and performance guidelines, that actually creates a tickler, an alert to our program, where then we reach out to the prescriber, physician, through our medical director to actually do an intervention to find out the reason for that and then resolve that inappropriate regimen.
One of the things that we learned too as we implemented an insurance program where we're starting to pay premiums, deductibles, and co-pays, really taking a look at the difference in what many of us call straight ADAP or medication assistance versus the insurance premium, and differentiating those two programs and seeing the really cost savings to get as many people on insurance as we can. So that's a cost containment strategy as well, and so we've really spent some time trying to move people to the insurance premium payment program. And I think that without the data, we knew some of that instinctively, but it really helped to show the decision makers in our department that this is a great way to go.
We actually encourage and we're trying to move people more towards our insurance side of the house, and because that offsets some of our financial projections of that. So data is very important to our program in monitoring month to month where we're going in that direction.
We will see continuous growth, and the funding just has to keep up with that. The drugs are not getting that much cheaper, if at all, and so it's an easy thing to communicate to our legislators and that kind of thing, that we need funding to keep pace with the increased demand. You know, it's really a good problem to have, that that the medications are good and people are living longer and we're seeing better health outcomes, but it's more and more people are living with HIV and they need the medications, and our program serves a lot of people. Throw in an economic crisis and, you know, you've got another increase in demand for our services. And so having the data to show that historically has been very helpful.
We're pretty transparent. You know, we share that data. Particularly the projection data is real helpful. Usually I go out into the community during the year and give updates, and a lot of it has to do with budget updates and expenditure projection updates. And you know, if we're short, you know, it looks like we're going to come up short in the next biennium or the next couple of years, then I let the community know that, and it generates some advocacy, and we try to resolve those issues, you know, with the legislature and with the community, and it's been effective. It's worked.
Many of our assembly members have been very impressed with our program and the fact that we can demonstrate our work and our efficiencies, and our data do project that.